present the most, I would say, glamorous neonatologist that we know
Oh, oh no, you get a bit of
Nadia Badawi. She's a chair of the Cerebral Palsy Alliance in the University of Sydney and medical director and co-head of the Gray Center for Newborn Intensive Care. What she doesn't know about cerebral palsy isn't worth talking about. So she's going to give us an idea of how we can improve neurodevelopmental outcomes of babies in our NICU. So as usual, I'll mute everyone on entry to this chat. If you have anything that you need to ask Nadia at the end of the talk, she'll leave some time for questions and answers. She's also got a team from the CP Alliance with us. Please post it on the chat or raise the hand icon. So without further ado, Nadia, the show's yours. Thank you so much.
Well, thanks very much, Julie, and thanks for bringing our community together during this time of COVID. I think, in fact, the learning and education has really gone up in this time. And I think that we really are, as a group of health professionals, in the ideal position to help prevent cerebral palsy, because we know from the Australian Cerebral Palsy Register that at least 50% of people who go on to be diagnosed with cerebral palsy have spent time in a newborn intensive care unit or in a special care nursery. And cerebral palsy, it's one of those conditions that, surprisingly, even though everyone who works in neonatology knows it when they see it, it's actually one of those that there's been a lot of controversy about the diagnosis. What is it? And I think that the things we can agree on is that, so far anyway, it's a group of permanent disorders. It affects primarily motor function or posture. It occurs due to a non-progressive injury, and it occurs to the developing brain. And those are the things that we agree on. Now, the fact that I say it's non-progressive doesn't mean that it's not changing, because as people grow, there are, of course, effects of accelerated aging. And also, if you have spasticity, you're going to get pain, exacerbation, dislocation, contractures. So it is also, I would add, a complex. So to go back to one of the things where I say is that why is this an area that to date really there hasn't been as much progress as we would hope? I look back to when I started training in neonatology, and I was taught that really there wasn't much that could be done to prevent cerebral palsy, that we couldn't realistically improve the outcomes for people who were diagnosed with cerebral palsy. And most of the focus of research was on the birth process, because people said, oh, it's all birth asphyxia. So as a result, we have an extremely high rate of cesarean sections. And the main emphasis then of therapy for a child was usually not evidence-based. We all, without naming some of the practices, you'd have children just having their limbs passively stretched, and they'd be in these exercise programs which were mostly passive, sometimes for hours and hours and hours a day, at huge cost to their family financially, but also the social relationships in the family, based on very little evidence. And then I was lucky enough to go and do my PhD with Fiona Stanley, Eve Blair, Jenny Korinchuk in Perth, and I was introduced to the Western Australian Cerebral Palsy Register. And it is the parent, it and the Victorian Register, the parent register of the Australian Cerebral Palsy Register, as you can see here. This is our report. And also there are some other registers around the world, in Europe, that we work with, and other registers starting in lower and middle income countries. And those registers have actually shone the light on where we should be doing research. And I'll talk more about that later on. So when I go back to how complex this condition is, this is data from a paper by Iona Novak and colleagues, and you'll see that while we talk about motor function, a lot of people have other problems. Hip dislocation, which is painful and increases disability. We used to see it in 35 to 40% of children with CP presenting to the hospital. There are no programs where the rehab physicians are working very hard with orthopedic surgeons to do hip surveillance. And in some countries, hip dislocation has virtually been eradicated. Epilepsy, pain, intellectual disability. And one of the issues is feeding. And I was delighted to hear Nina Modi talk yesterday about how sucking and breastfeeding can actually improve the developmental outcomes for babies. So a colleague of mine who's a speech therapist, works with Iona and Kathy and I, is doing a PhD and study on helping babies who are at high risk of cerebral palsy learn to suck. And I think it was great to hear that that might actually help their progress in other ways. One of the things that I want to give you hope, why is this worth working in? Because with a little bit of effort over the last 15 years, we've seen from our register that there has been a significant drop in the rate of cerebral palsy in Australia. It's gone from 1 in 500 live births to 1 in 700, a pretty dramatic drop. And it's a 30% drop. And that is really very pleasing to all of us. But what's even, I think, even more exciting to me and my colleagues is that those children who are being born now with cerebral palsy are more likely to have less severe CP. They're more likely to be able to walk and less likely to suffer from those comorbidities that you saw in that earlier slide. So they are more likely to have normal intellectual ability, less likely to have epilepsy. And this decrease is starting to be seen elsewhere. So this is data from Europe, where they're showing a decrease as well, and they're showing a decrease in bilateral spastic cerebral palsy among normal birth weight and moderately low birth weight infants. And of course, I hate to boast and gloat, but I think we should be very proud that so far Australia seems to have the lowest published rate of cerebral palsy in the world. So we know that because CP is a very complex issue, it's hard to think about it neatly. So in a way, almost arbitrarily, it's easier, I think, to think of it as premature cerebral palsy, term cerebral palsy, prenatal and perinatal, and then postnatal cerebral palsy, because this gives us a way or avenues to try and address the issues. Prematurity, if you look at this pie chart, you can see that from the register that about 43% of Australians who have cerebral palsy were born prematurely, even though they only represent 7.2% of the live births. And in Australia, we actually have one of the lower rates of prematurity in the world. And because none of us work in a vacuum, we have to think that we're actually part of a larger society. So decreasing prematurity is difficult. But when you look at some of the big changes, we see that actually the cessation of smoking in public places was associated with a drop in prematurity. The impact of COVID, there's been a paper in Lancet Public Health by Bean showing that there's been a drop in premature birth in Denmark and in Ireland with the COVID strategies of social isolation. They're not sure why, but they say maybe less infections in pregnant women, less stress, and we've seen this. Will it translate into a drop in cerebral palsy? Well, we assume so, but then again, that needs to be studied. There are individual strategies that can reduce prematurity at the obstetric level. And of course, I'm not an obstetrician, so I won't go through those. But there's a Cochrane review out in 2018 by Medley et al., showing that midwife-led continuity model of care and some others can reduce premature birth for the individual woman. I'm highlighting the midwife-led continuity models of care, even though I'm married to an obstetrician, because this is a theme that comes out in several other important studies. And I think that we as health professionals have a role to advocate for pregnant women in society and also with our obstetric colleagues and midwives that we work with. So one of the highlight studies is the Western Australian Preterm Birth Prevention Initiative. And I know Julie had invited Professor John Newnham to also talk about it. This study was recognized as a work report of major impact by the American Journal of Obstetrics and Gynecology. And this has reduced prematurity in their area by 8%. Now that's 200 babies that avoided being born prematurely. And if you look at them, the models they used were not drugs. It wasn't a strict medical model, but it was some very interesting initiatives around a preterm birth prevention clinic, public health campaigns, social media. And this is about to be expanded across Australia and also in Canada and the USA. And I think we should be very proud of this because John Newnham, in recognition, was actually chosen as the Senior Australian of the Year last year. In another model that is really important as well and has some commonality is the birthing in our community model, because these are Aboriginal and Torres Strait Islander women have twice the rate of premature birth as other Australians. And it's high, it's nearly 12%. Having a birthing on community model which empowers Indigenous women and provides increasing Indigenous midwifery practices. And they have a marvelous website. I urge you to go on it. It's really strategic. It's beautifully done and involves men. It involves a lot of people in the community. It's really something incredible, which I hope will be launched. And this brought the premature birth rate 40% reduction. We're hoping that this will be spread throughout the country outside a research model, and that it will also be associated with a drop in cerebral palsy. And I think it's an example too that the models that we use need to be individualized to the local context. We can't just take something that works for one country or one group of people. It actually needs to be tested in the community. And it's one of the things that we know, that models that work in high-income countries may not work in low-income countries. And that's, something that we also need to reflect on. For the babies who are born prematurely, I think it's really impressive to see the survival rate. This is for babies who come into our newborn intensive care units. Basically, if you reach 27, 28 weeks, you have nearly 100% survival. Now, the numbers that are lower, 24 under, of course, one must be cognizant that some of those babies never reach our intensive care units. They may unfortunately pass away or die in labor ward. But we can be pretty confident from 25-week onwards that this is a really strong survival rate. And it mirrors, just to remind us that we are part of the bigger society, is that there has been a dramatic increase in the lowest perinatal mortality rates in the world. And what this does is it gives us the privilege of focusing on improving the neurodevelopmental outcomes. And this also is a real push for us to develop standardized NICU protocols for care. How is this? And we can see the fruit is already, we see it in our work, a really significant drop in the rate of cerebral palsy between 20 and 27 weekers. And an increase not only in the drop in cerebral palsy, but an increase in disability-free survival. So things have really changed for preterm babies over the last few decades. And when newborn intensive care started, they were really noisy places. I still remember lights on all the time. We were stabbing babies endlessly. The lights were on, as I said, radios were blaring. Parents weren't allowed except for limited visits. And we had a real uptick in the rate of cerebral palsy. People were talking about an epidemic of cerebral palsy. And some of our colleagues in obstetrics and other fields were actually, I remember being questioned and people asking, are you sure you know what you're doing? You've got so much disability coming out of your newborn intensive care unit. But over time, we have become much better at what we do. We're better at resuscitating babies. We intubate them less often. We ventilate them less and for shorter times. And there's a very good paper from Yo and Ki Louis and colleagues in the archives of diseases of childhood showing a significant drop in the rate of severe intraventricular hemorrhage in Australia, which is also being seen in other countries. And I'm going to talk again about data. I love this, our register report. I also love our Australian, New Zealand neonatal network data and the NICU report, because they enable us to measure the trends of what we're doing. There's also a very impressive one from the Canadian neonatal network, which allows us to compare survival and other outcomes between our newborn intensive care units and allows us to benchmark and allows us to also develop quality improvement initiatives at country level. I mean, some of the papers that are coming out now comparing data of Sweden, Singapore, Japan, Canada, Australia, it just tells you that we're really looking at this at a national level. And this is what our families want from us. They want us to do the best and they want us to stop competing with each other. And it goes without saying that the immediate perinatal period for a baby who's very premature is a time of extreme vulnerability. This is a picture that Kath Carmo, who's the deputy director of NETS, gave me. This is a baby, a prem, outborn, being resuscitated by the NETS team. You can imagine what a stressful that time is, not only for the baby, but the family and the team. And there they are, skilled, trying to do their very best. And we're seeing anecdotally improving outcomes from babies who are outborn. When I started in Western Australia, my training, babies who were outborn had a much higher risk of disability. With better protocols, outborn babies are getting better and better outcomes. And you know, it's so good to revisit what we do. So Mark Tracy, working with a team at Westmead Adult NICU, has been looking at the resuscitation equipment. Graham Polglaze in Monash, also looking at resuscitation. And, you know, this was a very important paper that Mark Tracy and his team published, showing that the self-inflating bags that we all use, 50% actually didn't do what we thought they were going to do. And he and his team are developing a simpler bag, which is maybe cheaper. And again, we might do this in a better way. Because Graham Polglazer's animal work has shown that we have an inflammatory cascade that is unleashed in the delivery suite that can adversely impact the brain of preterm babies. We also know that mechanical ventilation has a real association between brain injury, subsequent neurological impairment, and I think this is a beautiful paper from Paul Glaze and colleagues in pediatric research. And I know that he and his colleagues with Martin Klucko at North Shore and other people around Australia are working, and internationally, in this area. And you know, one of the things I do when I'm on ward rounds, we got these amazing monitors who tell us, you know, heart rates, saturations, blood pressure. And I think all of us worry that the most important organ in that baby's body, their brain, is actually the one that we do not monitor properly. And I worry about what happens there, because sometimes we get babies who come to our follow-up. Nothing apparently happened, and yet they have a very poor outcome. And it makes you wonder, what happened? What did we miss? And while we have amplitude integrated EEG, and lots of people are looking at the use of NIRS, including Pranav Jani from Westmead, Himanshu, who works with me, we're trying to work out what's going on. Can we do this better? These are things that we can work on, and I think we need to collaborate with our engineering colleagues, because they can help us. They can help us with monitoring, they can help us with the use of data, and help us predict outcome. They can help us perhaps detect when something is happening that could potentially be injurious, and then we might be able to really monitor cerebrovascular autoregulation, try to prevent ischemia, reperfusion, and prevent brain injury. And I think, again, we need to work with these informatics specialists and engineers. Now, to get back to why the reasons for drop in this preterm CP that we're seeing, look, it is complicated and it's multifactorial, definitely. So one of the interesting things, if you look at the data from the UNSW group, you see that with the artificial reproductive technology, there's been a big change in Australia. So we've really been pushing with the College of Obstetricians to have single embryo transfer with artificial reproductive technology. Why is that important? Because twins, triplets, and quadruplets are at a very high risk of cerebral palsy. And a lot of that is down to premature birth. So just having this drop, you see the drop between 2007 to 2011, a drop in multiple gestation deliveries with artificial reproductive treatment from 10% to 6.9%. And interestingly, when COVID started, a lot of IVF was put on hold. So I'm curious to see, are we going to see a drop in cerebral palsy related to this? And Melissa Lewig, who runs the unit next to me, was commenting about they had much less numbers of prem multiples in the unit around this time of COVID. The other thing that we, of course, very important in our, the drugs that we use are antenatal steroids. They decrease, we know from lots of RCTs that they decrease intraventricular hemorrhage significantly, and intraventricular hemorrhage is one of the biggest variables predicting cerebral palsy. It also decreases developmental delay. But one of the things that is hard, because we only enrolled 904 children in those original trials, the relative risk for cerebral palsy, yes, it's 0.6, but the confidence interval by antenatal steroids, but because we never enrolled enough babies in the trials long term and followed them up for that outcome, I can't prove it numerically. And William always reminds us, William Tarnow-Mordi, that this is the problem if we don't have big enough trials and we don't follow the children long enough. The other wonderful development has been antenatal magnesium sulfate, and there have been multiple Cochrane's and systematic reviews, and the most famous one, of course, being that with Doyle and Caroline Crowther, showing the relative risk of 0.68 with a number needed to treat of 63. And you see pretty similar numbers from the other studies. So in Australia and in the UK, it's recommended if a woman is up to going in before 30 weeks, going to preterm labor before 30 weeks. But if you look at this study from Romero, actually there's a study less than 34 as well, and we're waiting for the randomized controlled trials in Australia to see if we should be recommending it to women going into labor 30 to 34 weeks. What about the other promising therapies? Caffeine, so there was the famous trial from Barbara Schmidt, Lex Doyle and colleagues, protective effect compared with placebo. And there was a paper out just this last year from Loda et al. Suggesting that giving giving caffeine very early, day one, compared to after day one, also just for premature babies, prophylactically, not because of apnea, also reduced the risk of cerebral palsy. Delayed cord clamping, again, this goes back and forward. William Tarnow-Mordi and Himanshu and Jonathan Morris led one of the biggest trials on delayed cord clamping, while they showed increased survival, but not decreased disability. But we all have a sneaking suspicion it'll help. And there's this beautiful paper out from Dooley et al. In Archives of Diseases of Childhood, showing, in fact, in their randomized controlled trial, again, a reduced risk of death or adverse neurodevelopmental outcome, a trend towards reduced adverse neurodevelopmental outcome. So something we need to think about further. Erythropoietin, look, I keep hoping it's going to work. There are many animal reasons that erythropoietin should work. There's basic science, but I think the jury is still out. There was beautiful work from Linda de Vries's group showing that it decreased white matter injury and gray matter injury in PREMS if given early, and it has the possibility of brain repair. But again, we've all seen this beautiful study from Sandra Jewell and colleagues in the New England Journal Medicine this year, suggesting that high dose erythropoietin in that high dose in extremely preterm infants did not result in a lower risk of severe neurodevelopmental impairment or death at 2 years of age. But I'm still hopeful, as many of us are. Sometimes I think that it's a drug looking for a cure. So what about the term babies? So while the individual term baby is, of course, at much lower risk than preterm babies, they still contribute 57% of all cerebral palsy, basically because there's more of them. And we have seen, again from the register, a significant drop in the rate of cerebral palsy among them. We're waiting to see whether the registers in Europe will also show this significant drop. So what could be working in this group of term babies? We know from work on newborn encephalopathy and also from our register, and here is Sarah McIntyre and Shona, who have demonstrated from the register and from Shona's PhD that around 30% of all people with cerebral palsy have a congenital anomaly. The reason we under-recognize this is that these babies get excluded from encephalopathy trials, from CP trials, and yet this is a really rich group. What I found very surprising from Shona's work is that they are the group with postnatal cerebral palsy also have birth defects and congenital anomalies. Another thing to think about. And why is this important? Because this could also represent a preventative strategy for us, working in congenital anomalies. So some of it is kind of obvious. We know that we have much better antenatal diagnosis. So babies who have a congenital heart disease or a diaphragmatic hernia, they're almost all diagnosed during the pregnancy, and they get born in hospitals where they can get the surgery just next door or in the same hospital. So we no longer see babies with congenital heart disease or diaphragmatic hernia coming collapsed, acidotic, having already had a brain injury. So we think that this is part of why term babies have less cerebral palsy. We also have to accept that, of course, some families who have a baby with an early antenatal diagnosis associated with a brain anomaly may elect to have the pregnancy terminated. And of course, cooling. And this is results from many trials, but including the fabulous ICE trial that was run by Sue Jacobs and Rod Hunt, showing that we get a 15% drop in cerebral palsy following therapeutic hypothermia. And again, one of the beautiful things is that within a year or two, this became the standard of care in Australia and New Zealand because we met as a group. It was recommended by the Department of Health. And this is really fantastic because so many therapies wait 20 years to be implemented. But I think as a group of health professionals, we got onto it very quickly. And the other thing is that the transport services are now implementing this very early. And if they can't do active cooling, they're doing passive cooling. So again, that transport teams are helping us, and they are a very important part of our teams. So it helps 1 in 6 babies who have had HIE. What about the other 5? The reason that it probably doesn't help everyone, and this is ways that we need to work together, is that we don't stop all the apoptosis or programmed cell death. We can't prevent all the neuroinflammation. So we really have to look at other neuroprotective strategies. And these will work at different levels along that cascade. The most promising of those is the erythropoietin study, which is the PIAN study, which is being done in combination with cooling and led by Helen Liley. And we really are looking forward to seeing whether that can help decrease the disability again. Also, stem cells, there's animal data from Monash, and our own team are looking in that area to see whether umbilical cord cells given with cooling can help. Data from Michael Cotton and Joanne Kurtzberg from Duke. Again, we're looking to see, could that help? And it's an emerging field. for all of us. One of the areas that really we need to look more into, and Sarah McIntyre again has drawn my attention to it, that hemiplegia has not decreased in Australia. We don't see less of it. And we need to look, because stroke is potentially preventable. But that is an area that really has eluded us so far. And yet hemiplegia is one of the areas that early intervention has been demonstrated to make a difference for children. What about the postnatal cerebral palsy that has also decreased? And there are many strategies. Screening for group B streptococcus. I would say that all of us would agree with. Intrapartum antibiotics is helpful. Vaccinations avoiding meningitis. Better care for babies undergoing congenital heart disease. Just talking to our surgeons and our anesthetists about protecting the brain around the time of surgery, using NIRS, just getting people to think about it. What about the babies with inborn errors of metabolism? They used to come in acidotic, comatose, high ammonia. Now with the new techniques around tandem mass spectrometry, we're not seeing babies coming in that condition. The public health policies, the compulsory car seats, missing near drowning by having swimming pool fences, the Don't Shake Your Baby campaign, all of these working together. It's not just about what we do in the NICU. It's working with everyone to bring these rates of disability down. And I go back to every time we fix a problem, it ends up coming back around. So we need to have data systems so that we measure what we're doing constantly. And this is a baby who has jaundice. And this is beautiful work led by Angela McGillivray and Nick Evans from Royal Prince Alfred, who noticed that more babies had started to come in with kernicterus. I mean, we thought we'd solved this issue. And what was happening, we think, is that these babies, we had the early discharge policies from maternity hospitals, and unfortunately, it actually struck women who were from non-English speaking backgrounds more. We just noticed that they tended to be migrant families who didn't know how to access the right help. Perhaps we didn't recognize jaundice in them. And to see this come back was really quite disheartening for many of us. And also it reflects one of the issues that we're starting to see is that there's a huge socioeconomic effect of socioeconomic deprivation on cerebral palsy. This is work that Sue Wolfenden is leading around from UNSW and Sydney Kids, and she's really highlighting that families from lower socioeconomic backgrounds are more likely to have a child with cerebral palsy, and the child is more likely to have severe cerebral palsy. And this has been shown in Ireland and in Canada as well. And again, the cerebral palsy registers enable us to look at this. So the good things and the bad things that we do that impact on disability are shown in our data registers. One of the biggest factors for risk for encephalopathy and for cerebral palsy is intrauterine growth restriction. And this is an area that obstetricians are focusing on, and often they form part of a causal pathway. And there are challenges. Obstetricians may diagnose growth restriction, but then they're not sure, should they be delivering them early? Should they be delivering them by cesarean section? There are risks in that. So these simple practical issues are still a problem. There are trials of melatonin, sildenafil, creatine, and we'll see whether in fact they may help decrease this risk. One of the factors, again from our register, and this is Dr. Hayley Smithers-Sheedy's work, shown that cytomegalovirus is a risk factor probably in up to 10% of term cerebral palsy. And we have launched, again, with obstetricians and the colleges of midwives and with the community, with family groups around CMV awareness, a successful public social media campaign to prevent CMV transmission to babies in utero. A continuing educational module for midwives has been launched in Australia, and if it works, it will be rolled out globally. And we've had a recent international consensus guideline that's been published. And a number of these are occurring around the world. And, we're also calling for a debate for universal neonatal screening for congenital cytomegalovirus, a very old-fashioned virus. And mothers keep telling Hayley and Sarah and I and all of us, I knew about listeria, I knew about group B streptococcus. How did no one tell me about congenital cytomegalovirus? Again, from the registers, we have worked out with studies, and this is one of the world's first studies showing that about 14 to 40% of people with cerebral palsy have an abnormality in their genome. And if you remember the 30% of people with cerebral palsy have a congenital anomaly, it's likely that the group with the genome abnormality and the congenital anomalies are going to overlap, and that there's going to be a lot of highlights and guides to how we can prevent or ameliorate cerebral palsy in this group. And this study was one of the first to be published in the world in 2015. And last year at the American Academy of Cerebral Palsy and Developmental Medicine conference, there was 2 whole days of presentations and studies. And I'm highlighting the gene editing work. I know it sounds very fanciful, but this gene editing technology, which I was delighted to see that 2 women got the Nobel Prize, were awarded the Nobel Prize for this year. I think this may work in the future and will provide another avenue to help these families. Now, I've talked a bit about the science, the trials, but I want to talk about the immeasurables, the things that I think really work and that they're hard to quantify. And this is where our nursing colleagues, our allied health colleagues are so good about reminding us. So skin to skin, pain management. I mean, we just have been so development. We heard yesterday from Nina Modi that just sucking and breast milk will improve brain development. So we need to work with our nutritionists, our dietitians, our lactation specialists. And this, banking of breast milk, this will have a huge impact, I'm sure. Improving the NICU environment. Having parents like this baby's on a ventilator, and there's dad, mom reading to the baby. Noise control. Also NIDCAP. So our unit, the Grace Center, I'm really proud that we are Australasian NIDCAP Training Center. This is Nadine Griffiths, one of our clinical nurse consultant who's doing a PhD in this, working with one of our mothers, talking about newborn individualized developmental and assessment program, making everyone think about development. And behind her is the green dot, which talks about the goals that we want the babies to achieve, also the cues. And this is something, it's part of what we are all doing every day. Early detection, so for those babies whom we can't protect from having a disability, we need to detect it early. This is Catherine Crowell, our senior OT. She is doing the general movements assessment on a baby in the unit, and this has a very high fidelity of detecting cerebral palsy early by 3 months. We're all doing it in our units, and this is incredibly important. Kathy Morgan is now one of the 2 trainers in Australia. If anyone wants training, please email her. And why is this important? Because we don't know, we haven't been able to intervene early. Adults who have a stroke get active early intervention within a couple of days. We're diagnosing our babies so late, unless they have severe CP, that we don't know what early intervention works. Now, because of early detection, there are now at least 8 randomized control trials happening in Australia, multi-center trials of active intervention. Parents want it. They tell us that they want to know early, and they don't want to be protected from the diagnosis. This enables us then to do our neuro-developmental follow-up. And really, isn't it fabulous? And this was one of the things David Henderson Smart pushed. We all have follow-up programs. PICUs don't have them. Adult ICU don't have follow-up programs. I mean, the adults tell me their success is if the person is alive. For us, we're actually following them long term and learning from that. Also, I want to draw your attention these guidelines for the early diagnosis of cerebral palsy. If you don't believe me, these are international guidelines which were published in JAMA Pediatrics, and the lead author is Iona Novak, and it has been cited nearly 400 times since it was published. And this has leaders in cerebral palsy work, very important paper. So here, and actually because of it, we now have an early detection clinic in Prairie Wood and an early intervention clinic. It's a world first for babies with cerebral palsy. I've talked about the science, the guidelines, but I want to draw you to the intangible, the stuff that I think makes such a huge difference. This is Alyssa Fraser. She is one of our CNCs and educators. She's here in the middle of one of our readathons. She's got a little sticker on, which was launched. She's reading to one of our babies in the courtyard. There's a mother behind her who's also reading to having her baby read to. And this readathon has been taken up by nearly 30 units around the world. We all read to our babies. We need to be reading to the babies in NICU because this will improve the outcomes. Can I also remind us about our lower and middle income country colleagues? CP registers have been launched there. So Gulam Kandakar and his colleagues have a register modeled on the Australian register in Bangladesh. This is providing essential information and services. We know they have higher rates of CP. It's more severe. And we need to also look at preventable causes there. We can't just adopt what we're doing willy-nilly. It needs to be studied. And I'm just, Bangladesh has moved from a lower income country to a middle income country. And as these countries become more affluent, they will develop NICUs. We don't want them to see that epidemic of cerebral palsy that we saw. We need to reach out, collaborate with them, and help reduce cerebral palsy in those countries too. I'm going to leave the last word to Hannah Divany. She's one of our ambassadors. She's a young woman who is incredibly intelligent, a university student, an author, and she has been supporting us in the quest to try and prevent cerebral palsy. This is her quote. You can read it. And she wrote for Miracle Babies. And why am I highlighting them? Because they're a parent support group. They are also very keen on working with us around the prevention of cerebral palsy. And I've talked to many of you. I sometimes don't know why we've had such success, all of us, but I think if we raise our expectations, we will get improved results. We do need to have a suite of neuroprotective interventions that we update regularly, because I know that I find it confusing. Should I be giving caffeine to the babies in the unit as soon as they front? Should I be using EPO or not? And that's the kind of thing that we need to do together. Thank you. I hope.
Thank you, Nadia. Wonderful talk as usual. You have a couple of questions, several questions online, and thank you, Kathy, for posting your email up. So, Kathy, I hope you can all see it. Otherwise, just email me for Kathy's email. From Dr. Nitesh Agarwal, he says that the prevalence of congenital CMV seems to be very high in Australia. How do you explain that, and what strategies are being tried to detect and prevent this?
Look, it's really interesting. We know how high it is in other countries? So for some of you know, I'm half Egyptian, and I worked in Egypt while I was training, and I don't ever remember thinking about cytomegalovirus because there were so many other infections. So I actually don't know whether it's higher or lower, but here it is something that I think we know that at least 60 to 70% of Australians or people who live in Australia have had cytomegalovirus, and for most people it's innocuous, though it can actually leave side effects in some adults. But I think we know from our registries, from the newborn screening, that it can actually affect unborn babies. And there are some simple strategies around it. When a woman is pregnant, hand washing, you know that thing we all do, all the mums and dads are going to groan when your toddler's dummy falls on the ground, you pick it up, lick it. Don't share toothbrushes. Don't share food. Don't share cups. So when the nappy's being changed, wash your hands. Simple strategies that we actually haven't warned people about. And that's what the strategies Hayley is developing with Antonia Fraser and the midwives around educating people. I think that's going to have a huge difference. And I know that my husband's an obstetrician, and honestly, he told me he'd hardly ever thought about CMV. He was horrified by Hayley's results and immediately took up all these posters from Hayley, which he has all around his rooms. And some people said, but you're going to be ruining pregnancy for these women. Another thing to worry about. He hasn't had that response at all. Women have said, thank goodness, something that I might do that is so simple.
That's right. Okay, next question from Dr. Sam in Singapore, Nadia.
Hi, Sam.
Yes, Sam, he asked, what interventions would you recommend in term infants where most of the insults will occur antenatally?
Oh, yeah.
Whoa,
the magic.
Sam, you want to unmute yourself?
That's where we need your help, okay?
So that's a very open answer, Sam.
It is very, very. I think that's hard. I think, look, for term babies, again, being a multiple birth is a risk.
Right.
So I think and I've seen in Australia at least, a lot of people, because there's a single embryo transfer now, and because it's so expensive, we're seeing a lot of people going overseas and coming back with multiple births. So I think that is a simple strategy that we could use to advise people that having a multiple birth is a risk for cerebral palsy, even if they're term. Though I admit it's lower with a term baby who's one of a multiple birth. Growth restriction, that is an area I think we can all be working in. But watch this space, hey?
And question from Mark Tracy. So,
hi, Mark.
Mark, are you going to unmute yourself?
Yes, hello. Nadia, look, I made a comment and I think it leads into a question. Look, wonderful talk as always. The intangibles slide was tantalizing, and for those that know me, I want to measure everything. I think we can measure the impact subtly and without distraction of the mother and the child, or father and the child, in that lovely image you had, with wireless linkage devices that have minimal impact on the child, and not just in the
I agree, actually. I really, yes. And that's a good idea. There you are. Let's do it.
Okay, so Mark, there you go. So look, a question from Rodney on everyone's minds. Nadia, he asked if we can prevent postnatal CMV in prems.
Now that is, that, oh, I know. And actually that is a challenge that we are thinking about. And actually people from Sydney Kids and from UNSW are working with Hayley on trying to address that question. And it worries me too, Rodney, that we see it. There are some treatments developing, and there's a drug that's name escapes my mind that has been shown to help. So we do need to be looking at that, yes. And I think the same things about hand washing will probably help.
Sam has one more question. Maybe Sam, you're unmuted. Can you ask it? Yeah. Mm-hmm.
Nadia, excellent talk this morning. You know, I go to the regional countries, Cambodia, Indonesia, and some Bangladesh, South India, to improve the neonatal care.
Yes.
What low-cost strategies will you suggest for these low-income, middle-income countries, please? Yeah.
So I would say skin to skin is probably important. Delayed cord clamping, I think that is something that we can do.
Yeah.
I think those are the big ones. And I'm very loath to perhaps talk about drugs because, and that's something that we've been thinking about, is magnesium sulfate. Are we sure it's going to work? We don't know. Antenatal steroids. I think that's where we really need to do trials with other countries.
Okay, and Srini has a comment. Don't know whether he's going to run off or not, but he's saying that France has taken the initiative of freezing breast milk before administering for all infants below 27 weeks.
What do they do? They
freeze their breast milk.
All right. Yeah. Okay. I didn't know that. And with the aim of?
Getting rid of the CMV.
Right. Okay.
Yeah. Okay, so he's gone. And from Dr. Yi, he says fetal growth restricted babies are increasingly surviving, but having great morbidities. Yes, we've seen that. So are you seeing similar increasing trends? And is there anything we can do to prevent this?
So I think it's participating in the trials. I think that's very important. And I know that Salish Kumar from Queensland is wanting to do a trial of sildenafil in intrauterine growth restriction, because that is, and it's such a complex area, because so many of those growth restricted babies also have congenital anomalies. So it's not straightforward. And I think that's really, that is such a big area that we do need to work in. Yeah. And I know that there's work also at RMIT, David Walker and Mary Tolkos and their group, looking at creatine, melatonin, Ewan Wallace. So there are lots of trials happening.
So maybe we can ask William to comment. He's online. I think he's very much associated with Sailesh Kumar's study. William? He is muted. No, never mind. Okay. Anyway, so is there any comment from your group, Nadia, your wonderful group, Iona and Kathy, online before we end? They're too shy. They're still eating?
Oh, Kathy's not shy.
I'm not too shy.
Okay.
Look, I just think we need to really think carefully about who we are screening. I think because we've got resourcing issues